thank Dr. Cassio for putting on such a good symposium, and Jada and Laura for organizing it. I've spoken at this a number of times, and every year it seems to get bigger and better, and hopefully we'll all learn something at the end of it. How many people here are physical therapists or athletic trainers? Okay. How many are coaches? Okay. How many are parents? I guess we're all parents, I guess. All right. So certainly a diverse group. And I'd just like to thank all the athletic trainers and therapists that work with athletes. You do all the hard work. You're there day after day, meeting their needs, getting them ready to perform. And you make our job a lot easier, so I'd just like to thank you. Okay. So we're going to talk a little bit about sickle cell. I look back, I did a similar talk to this 5 years ago, so if you're here 5 years ago, it's a little different, but there's not a lot that's changed in blood since then, okay? So what are the causes of sudden death atraumatically in athletes? Well, certainly we know about sudden cardiac death. We know that unfortunately asthmatics get out of control and can die, which is truly unfortunate, okay? We all know at this time of year in the South about exertional heat stroke and heat-related illness. But believe it or not, exertional sickling is a very important component of people, young active people who die suddenly. And perhaps it's underdiagnosed because we're looking for that cardiac disease, we're looking for other disease, but the underlying pathophysiology may be sickle cell. Okay? So you guys are in the front lines. This is probably a good slide, okay? Because when somebody goes down, what do you need to do? Okay? First of all, I'll tell you, if they're unconscious and not talking, that's never good, okay? That's where you activate your action plan and get EMS there and get the AED out if you think that that's appropriate. Certainly get a monitor. But remember, if they can't talk and they're unconscious, that's most likely cardiac. The ones that are anxious, can't breathe fast enough, and have a history of asthma, it sort of makes sense that it's probably an acute flare of their asthma. The difficult ones get down to the exertional heat stroke. They are confused, and that's probably the hallmark of it. I don't know how many of you have a rectal probe thermometer in your training kit, but I don't think too many, nor is it appropriate to whip it out in the field and see whether somebody's temperature is elevated. Okay? But remember, these are people that are confused, and that's probably the hallmark of it. Obviously, if you're from Canada, where I'm originally from, we don't see heat stroke in January. We do see it in July and August, just like you do down here, except your summers go from May till October, I think it is. So you certainly have a much greater experience than perhaps people north of the 49th parallel. Okay? They may have seizures, which is frightening. Okay? And usually they're later in practice. Okay? What about exertional collapse associated with sickle cell trait? Well, these are people that are conscious, they can talk, they sort of just go to the ground, okay? And it may occur either early or later in practice. They may complain of cramping either in their extremities, sometimes in their abdomen, and so these are people that are sort of fall in between. So if they can talk and they just go down and they complain of cramps, that's when you need to activate this type of plan. Okay? So I think that this is, for people that are in the front lines, the first responders, the trainers, this is, I think, is helpful to you. Okay? So what is sickle cell trait? Well, it's an adaptation of the body to, I hate this slide, I should have changed it because it takes too long and I'm not very patient, okay? It's an adaptation to actually malaria from Africa. And it certainly is more prevalent in blacks, about 8%. So 1 out of every 12 people may carry the trait. It's less common in Hispanics, and it is even less common in Caucasians, but remember, it does exist. So it is predominantly occurs in blacks but can occur in others. Okay? So the color of your skin doesn't determine whether you have sickle cell trait. So this is really what it is. As you know, hemoglobin carries oxygen, and if you're not carrying oxygen and you're exerting yourself, you'll get an anoxic or hypoxic supply to the muscles, and that's where you get into trouble. People normally have 95 to 98% of hemoglobin A, which is the primary one. People with true sickle cell disease predominantly have hemoglobin S, and the ones with trait have you'll see a little higher incidence of the hemoglobin S. Okay. So who is required to, how do we detect this? Well, every baby that's born has sickle cell screen done. Okay? But most people don't know what the result is. Okay? Obviously, if it's positive, okay, with the trait, or certainly with the disease you certainly declares itself relatively early. It makes it a little easier. But my mom never told me much about when I was little. I don't know what your mom told you, but it's something that's sort of lost in time. Okay. So we screen for it. All newborns in the state of Louisiana have sickle cell screen. Okay. If it's positive, then we do what we call a hemoglobin electrophoresis. So the screening is a solubility test, and then we go on to sickle cell screening. Sickle cells, when you look at red blood cells under the microscope, they're nice and round. The ones with hemoglobin S, sickle, and this mainly predominates when there's a requirement for oxygen, so high demand exercise. Okay? So what puts it at risk of exertional sickling? Okay, so oxygen demand, okay, lactic acidosis, which obviously goes with exercise and can go with some other things such as illness, severe sepsis, and other things, overheated muscles, okay, dehydration, okay. And as somebody has said, the harder and faster an athlete goes, the earlier and greater the sickling with sickle cell trait. So what happens here? It's an intensity syndrome. It's not a heat-related thing, even though it does occur with heat-related illness, but it's really the intensity of what you're doing, okay? It's not a significant risk factor, though it does put you at a little greater risk, okay? And many times, a sickling death is misdiagnosed as exertional heat illness or cardiomyopathy. And so that's why I said I think this is an underdiagnosed problem, because as soon as we find one problem, that's what we leave it at. So if they've done an autopsy on a young athlete that's succumbed, and they find a hypertrophic cardiomyopathy or a thickened heart muscle, which many athletes have, they often leave it at that and don't go the extra step and look for the sickling component of it. Okay? So this is what happens when you exert yourself. This is the pathophysiology. You exercise, you get volume depleted, your muscles overheat, you get acidotic, there's more oxygen required. However, the red cells are starting to sickle with this intensity and the demand. It causes them to change shape and sickle, causes the whole system to get inflamed, and that causes sort of what we call microvascular inclusion. In other words, the blood cells clog up the vessels, and that's where they get the pain. So whether it's cramping, okay, whether it's muscle breakdown, whether it's an infarct to the kidney or the spleen, that's the result of the sickle sort of clogging the vessels, okay? That causes them to collapse, and that unfortunately may lead to death. So if we can identify this early, obviously earlier in the cascade, then I think we will be able to prevent the last component of it, okay? So why is it important? Well, obviously death, okay? But it can have sequelae. Rhabdo, muscle breakdown, as I said, talked about many of these things. It can cause some hyperkalemia, which can lead to arrhythmia. Believe it or not, people with sickle cell trait that have had recurrent episodes are at a greater risk of some forms of cancer. That is very rare. Okay? Risk of death to a person with sickle cell trait is 10 to 40 times the average person. So this is why we have a need to identify it and prevent it. Okay? Okay. And again, obviously, as I've said, it's related to the intent. It's an intensity thing, and certainly other factors influence it. Whether they have an acute illness puts an increased metabolic demand on them. If their asthma is not under good control, they're not oxygenating. If they have an acute illness, or sometimes going at altitude, as you know, is where the oxygen dissociation curve shifts to the right, and then you get in trouble. Okay. So what do they get? They get pain, okay? My muscles are cramping, and it's sometimes very hard to differentiate this from just muscle cramps, okay? Again, the pathophysiology is, as we sort of have reviewed earlier, okay? Sometimes they'll have what we call gross hematuria, or they're peeing blood, okay? And again, that's due to the injury to the kidney. Occasionally, it will infarct an organ such as a spleen, okay, and they may complain of left upper quadrant or left lower quadrant pain. And again, these are at the extreme. Hopefully we don't get to that point if we recognize this illness early, okay? So what do we do, okay? First thing, as I said, recognize it, okay, that's half of it. Get them out, okay, cool them, treat it very similar to heat-related illness. If you have oxygen, give that to them, because again, that helps with the underlying pathology of the sickling. It's not carrying the oxygen. Give them fluids if you can, orally, okay? If you have IVs, that certainly helps, okay? And once you've recognized it, they need to go somewhere else, okay? This can potentially be life-threatening, okay? So if we identify it, treat them appropriately, we're going to reduce the risk of death. Okay? The first question any athlete's going to ask you, when can I go back? Okay? So here's just some simple guidelines on that. Okay? Obviously, they can't have any damage to organs. Okay? And that's, again, a medical monitoring process. But you can at least have a level of expectation. If somebody has had a sickling episode that has required medical attention, at least you know that there's a process that we go through to ensure that they can return to activity safely without increasing their risk of recurrent episodes. Okay? Supervised athletic training physicians, okay, just like with the concussion and graduated return to play protocol, we do have similar things. And it's gradually, it just makes sense, gradually easing them back into activity. Education, that's probably the paramount part, not only to the athlete, but to the family and the parents, and particularly the coaches. Okay. Sometimes we get these challenging decisions, and I'm not going to spend a lot of time on this. This is really just for your reference. But this is sort of the process we go through of trying to determine who gets to continue to participate, who doesn't, and who's at a little greater risk, okay? This is really in an acute situation, okay? Okay. How do we prevent this? We all know it's much easier to prevent a problem than it is to treat it, okay? Well, we need to confirm what's been done when they were born, and if we don't have that information, we should obtain it. The NCAA in 2010 required this for all Division I athletes. So if you can't produce the piece of paper, you get your blood done, okay? So once we've identified somebody with sickle cell trait, they are at risk, and we need to educate the people that are looking after them or training them, okay? That includes strength coaches, okay? That includes their maybe position coach or whatever, and at this time of year, certainly football starting, people need to know who carries the trait, because in the old days, suck it up, buttercup, can kill you now, okay? So we just really have to be aware of it, and the approach is to do this for everyone, okay? You know, with HIPAA and other confidential medical information aspects of law in America. We need to respect that confidentiality of the patient. So the better approach is this should apply to everybody rather than just those with sickle cell. I think we'll certainly decrease our risk of heat-related illness and dehydration, rhabdomyolysis, if we follow these principles, okay? So avoid dehydration, gradual conditioning regime. That's why we don't have two-a-days right at the beginning of training camp anymore. If they don't feel well, listen to what the athlete is saying, okay? And yeah, sometimes they have secondary gain. They're just, you know, deconditioned. They're not able to do what they need to do. But it's better to err on the side of caution than wish you had, okay? And if you know that this athlete is, and certainly trainers will know, but coaches may or may not know, the specific individuals, let them go at their own pace, okay? They're not sandbagging it. They really, their body's telling them what they can and can't do. And again, this is just a reiteration of what I've, it was in the previous slide, but a little more information again for your reference, okay? Making sure that they're well hydrated is essential, okay? And especially with our weather at this time of year, this is what we have to do. I always smile when I see on TV people running IVs on sidelines, okay? Because somebody's volume depleted, okay? That means I haven't done my job as a physician, okay? Because I haven't educated them enough that they have been hydrating themselves well enough, okay? To me, when I see an IV hanging, it's my failure, okay? So we have to educate our athletes, and particularly kids with sickle cell trait, we have to over-educate them, okay? So I don't like IVs. I don't think they're really necessary because the oral fluid replacement is just as efficacious, okay? Do I run them? Of course I do, but I don't like them, okay? So prevention, obviously education, as I've mentioned, okay? Not only the athlete that they have a disorder that puts them at risk, okay? That they have to recognize their limitations, that they are responsible for hydrating themselves, okay? Certainly even at the collegiate level, you'd think that 20 and 22-year-old semi-adults, I guess, would understand that, but you have to sometimes treat them like children and just remind them every time you come off the field or off the court or something, you should be taking fluid in, okay, especially in these conditions. Okay? We need to educate coaches, okay, because those are the ones that are trying to maximize their performance, and often they feel they never have enough time to do that. So they want to push and compact everything into shorter periods of time. These individuals cannot do everything everybody else can, okay? They have to listen to their own bodies and adjust, okay? And coaches need to understand that, okay? The old tradition, at least when even I played high school basketball, but I remember when we did something wrong, we had to run the lines, okay? And usually it was at the end of practice, and usually you were volume depleted, and usually your muscles were really sore. So you heat that on somebody that doesn't have a disorder, it's bad enough. Heat that on somebody with sickle cell trait, and you can really get them into trouble. So we have to adjust our mindset a little bit on that. Okay. We as medical staff are responsible. As I said, I see an IV hanging, I failed, okay? I need to make sure that somebody that's an asthmatic, that they're well controlled, because that may precipitate a crisis. We have to adjust things for altitude and heat, and I'm terrible with names, but I remember there's a professional football player that didn't travel to Denver to play in a game because he has sickle cell trait, and the altitude would have put him into a crisis. That's just good education. Okay? Monitor those who are at risk, okay? And make sure they're well hydrated, okay? They do real well, sickle cell trait athletes, if they're allowed to participate at their own pace. Okay. And that's, the rest are just references. Does anybody have any questions regarding that? I think this might be the better way of doing it. So let's go into real life stuff. We have a 19-year-old soccer player, has a sore throat and fever for about a week, some swollen glands. She plays goal, okay? No significant past medical history. She's on the birth control. Her last period's in progress. She's not allergic to anything. Okay? Everything's within 2 weeks. You know that. Okay? Or next weekend. So when we examine her, okay, and obviously the physician has seen her. She's got a fever. She has big swollen white tonsils, and I'll show you a nice picture. Okay? She's got swollen glands. Her liver is a little enlarged, and you're not sure whether you can palpate the spleen. Okay? And again, I don't expect people to fully understand this, but you are the guys that they're going to ask, when can I play? Okay? Because doctors are real poor at telling people that. But trainers and people looking after athletes, they're the ones that are going to get all the questions. Okay? And if you don't know the answer, then always send them back to their physician. Okay? So that's the big white swollen tonsil, what we call exudative tonsillitis. And as some people may know, you can't sometimes tell this from strep throat. Okay? We look for what we call petechiae, or little white spots or red spots on the palate or the hard part of the roof of the mouth, and that may indicate low platelets, which we'll talk a little bit about. So what test should you do as a physician, okay? And what should you expect as a trainer, okay? What things are they going to recommend? And the big question is, when can I go back and play, okay? So this is actually Epstein-Barr virus is the one that causes mono. It's a herpes-type virus. It's passed back and forth, okay, by oral contact. So if somebody on your team has mono, okay, don't let them share water bottles. As a matter of fact, the principle is never share water bottles. Nobody should share water bottles, okay? Buy shares in those little paper cup companies, because that's how you should dispense fluid, okay? Not out of a common water bottle, okay? Just being in the general area of it, okay? Most people will actually have mono as a child. It is more severe as you get older. When I had it, I was in first year university, and my platelets dropped and I started to bleed. My dad, who was a physician, said, get over it, okay? It's when I got encephalitis with it that it sort of, even he as a surgeon figured it out. So I was in the hospital for about a week. So as I said, it can go to that extreme, okay? The problem with it is it takes a long time to incubate. So you can come in contact with it up to 2 months prior, okay? And it does last approximately 4 to 8 weeks. So that gives you a rough time period. And if you told an athlete that they're not participating for 8 weeks, that could be a season to them. Okay? So obviously we've gone over the classic symptoms, and they often have a prodrome, a headache, a little bit of tiredness, muscle aches. What other virus doesn't have those symptoms, you know? The real clinical phase is usually when they end up presenting themselves to a physician. We look at a classic triad of a fever, which happens in about 3/4 of people, pharyngitis or tonsillitis, and sometimes you can't differentiate that from strep, and lymphadenopathy, and what we call posterior cervical lymphadenopathy. So that's what we look for. Okay. Other symptoms, like a myriad, like most viruses, can have anything. Okay. Lots of muscle aches, lots of tiredness. The classic thing is when you're treating a throat that you thought was strep and you give them amoxicillin, they break out in a rash, you probably made the diagnosis of mono, okay? It's one of hindsight. But amoxicillin is sort of the classic one, but a lot of other antibiotics can have the same effect, okay? The jaundice is from involvement of the liver, okay? Again, the physical signs, we've seen the pictures before, okay? I personally end up swabbing people that have exudative tonsillitis, because I don't know whether it's strep or whether it's not, okay? It's been shown that clinically you can only tell about 50 or 60% of the time, so 1 out of 2 you might be right. About half of them have an enlarged spleen, and we'll talk a little bit about that. And as I said, showed you those pictures of petechiae on the palate, and this slide has all of those things that we talk about. A little repetition, but that's how I learn. Okay. What do we look for in a lab investigation? Well, we look for what we call lymphocytosis, or the cells that can respond to viral type infections. Okay? Usually have more than 50% of them in a peripheral blood smear, and at least 10% of them are what we call atypical. In other words, they're misshapen. The test, everybody knows about the monospot, or it's called the heterophil antibody, and it's pretty sensitive and it's pretty specific. Unfortunately, there's about a 10% false negative and false positive. You can have it with other viruses like CMV, adenovirus, and toxoplasmosis. Again, most of those are really supportive care, except for the toxoplasmosis. It's not a true virus. It's not a virus. Okay, it can drop your platelets, and that's what happened to me. I think my platelets dropped to about 10,000. Normal's 150 to 450. And that's because the spleen gobbles them up. The spleen is like the carburetor in the body. You have abnormal cells. The spleen absorbs all the abnormal blood cells. And so it gets big when you've got lots of atypical lymphocytes, and that's why it gets enlarged. Okay? Liver tests will go up. Sometimes I'll measure them, sometimes I won't. Okay? So obviously we do the monospot. What happens if it's negative? Well, you repeat it in a week. Okay? If it's still negative and you're still highly suspicious, there's some fancy tests we do called IgM, EBV, nucleic acid antibodies. So, this is just a slide that shows you how the different antibodies, the IgM are the first line of defense. The IgG is sort of your permanent defense against mono. Is it possible to get mono again? Yes, okay, because in medicine, never say never, okay, but it's unusual, okay. So that's your natural defense against it. As I mentioned a little earlier, most of us have had it as young children in a, quote, viral illness or a cold that we've had, and that's why not everybody gets it when there's an epidemic out there amongst the adolescents, okay? Because we've developed antibodies to it. So these are just some of the things we look at as physicians when we're not sure, okay? What's in the differential? Well, other viruses, okay? Other illnesses. Always think HIV. Nobody likes to think of that now. There's a recommendation out by the United States Preventive Services Task Force that everybody over the age of 15 be screened at some point for HIV. That's just a public health recommendation. It's not an insinuation or anything else. It's just the reality that we live in. Okay? Other types of herpes viruses can cause things. Okay? So, Doc, when am I getting better, and how long will it take? Well, generally it takes about 2 weeks to get over the acute phase once it's been diagnosed. Okay? Usually a total of 4 to 6 weeks to get over the virus. Your immune system has to work. That's the only way you can do it, really. Okay? Sometimes it takes longer, depending on the severity and the duration. Okay? Sometimes it takes shorter. Athletes are not at any greater risk of getting mono than other people. Okay? It's just that sometimes they overtrain, and that reduces their immune system and puts them at a little greater risk. Okay? What do we do? Worry about the complications. You don't want to be like me. Okay? Don't have a dad as a surgeon. Okay? It's the first thing. Most people get over it, and a lot of people don't know they had it. Okay? What are the real risks? Well, everybody worries about somebody's spleen rupturing. Okay? Myocarditis, inflammation of the heart muscle, meningitis or encephalitis, which I had, and certainly hemolytic uremic syndrome is blood cell kidney disease. Okay? It does put you at a little greater risk of some malignancies, and sometimes you can have neurologic complications with it. Okay? Got to differentiate strep because 30% of them have strep plus mono. Okay? And I'll show you the Waldeyer's ring. These are the ones you really have to worry about, and these are the ones we end up putting in the hospital because of airway compromise. Okay? What about big spleens? Well, everybody, depending on your size, has a spleen that's proportional. So what's normal for a 6'6" person is not normal for me. Okay? And all of our references when they do ultrasounds are based on the average American male in the 50s, which our morphology has changed somewhat, okay? So there isn't really a normal unless you've had a previous ultrasound done. Okay? These are just things that doctors look at, the rule of odds and imaging, okay? Has anybody here had an athlete with a splenic rupture, either with mono or from pure trauma? I've had two. First of all, one was a football player that we didn't know had mono till found out he got hit in the ribs during the game driving back from Calgary to Regina, which is about 800 kilometers or 500 miles, and about 400 miles into it, he says, my left tummy hurts and I feel woozy. Well, we drove real fast the last 100 miles, so he got there, he had his spleen out, and he did well. So you don't want to be traveling when that happens. Okay? People can spontaneously rupture their spleen when they have mono or for an enlarged spleen for any reason. Sometimes just straining going to the toilet, okay? Obviously there's trauma, okay? Potential emergency, these are things we do an ultrasound or a CT to really see it. Most of the times it's what we call a subcapsular, and most people it can just be observed, okay, if they get into trouble, okay? Some people need to have their spleens up. And what we did 30 years ago is different than what we do now. Okay. Should we do an ultrasound on everybody that has mono? No, okay? Unless you have something that it's going to change your management in some fashion, or you have a reference of a previous ultrasound in there, because you don't know what's normal for that kid. Okay. Do I do ultrasounds on people with mono? Yes, okay? But I do it a lot more selectively now than I used to, because it used to be sort of standard of care. So how do we look after them? Well, we give them support, patience, okay? They need to rest, okay? Because their immune system is what's going to clear the virus and get them back to doing what they're doing, okay? No physical or strenuous activity for 3 weeks. That's the first thing you're going to tell them, okay? 3 weeks. So if it's, 4 weeks from the football playoffs, they may or may not be back. If it's 1 week, they're not playing. Make sure they look after themselves, just good basic principles. Avoid aspirin, and some people say NSAIDs like Aleve or ibuprofen. Again, they have what we call an antiplatelet effect, and that's really what we're looking at. Because if your platelets are low and you get something that sort of slows down the platelet effect, you may bleed. You're more liable to bleed. Okay. I don't think I've ever told somebody to use a stool softener to avoid straining when they have a bowel movement, but it just makes sense. Okay. And there's no evidence that some guru's diet's going to make them better faster. Okay. Again, you want to prevent this from spreading to other team members. That's basic hygiene. Okay. For those that are of legal age or perhaps not, avoiding alcohol, especially if there's hepatic involvement, and the virus does invade the liver about 4 out of 5 times, so avoiding alcohol, and I tell people, give it 12 weeks, okay? Nobody's died from not drinking, okay? Okay. What about steroids? Doc, give me a shot of steroid or give me some steroids, I'll get better. Well, it lasts for about 12 hours, but after that, that's about it, okay? So I have never prescribed it. My partners have. I've seen people at a very elite level use it, but there's no evidence to support it, okay? And there's always a risk with any medication, okay? When do we actually use steroids? Well, remember that one with Waldeyer's ring where that airway was compromised? That person would get steroids, okay? Really, it's to decrease the inflammatory response around the airway. Okay. Sometimes with the severe complications, we'll use steroids. Okay. And it's usually pretty high dose. Okay. What about, this is a virus, it's a herpes virus. We know that things like acyclovir, Veltrex, Famvir work against herpes viruses. So of course somebody looked at it, really didn't make any difference. Okay. Okay. So there's really nothing we have in our pharmaceutical armamentarium that's going to get them back faster. Okay? That's all myth, anecdote. Okay? It's the body's immune system. Okay? So usually 3 to 4 weeks after diagnosis, you can let them go to light activity, because that's what they're going to ask you. Okay? And certainly you're not making the decision, but you're the one that may have to hear the brunt of the whining and complaining. Okay? So we as physicians make sure they're not running a fever, that their energy level's starting to pick up, and you ask them how you feeling. Oh, great, doc. They all lie. Okay? And that we're not finding anything abnormal on the physical exam. Okay? Usually, they can resume contact sports at 4 weeks, usually. Okay? That's an individual decision. And clinical judgment, gray hair sometimes helps and sometimes hinders. Okay? Because the longer you've been around, the more bad things you've seen, and you tend to be sometimes a little more cautious. Okay? So really, what it comes down to is when you have an athlete with mono, they are going to be out a minimum of 3 weeks. Okay? If they're in a contact sport, they're probably not back for 4 weeks from the time of their diagnosis. Okay? And there's nothing anybody can do to speed that up. Okay? Unless there's voodoo out there, I don't know. Okay? We don't do serial ultrasounds, not really recommended. Okay? And we usually don't do a lot of follow-up unless there's something that we're concerned about. Okay? So if their liver enzymes were 20 times normal, I'm repeating the liver enzymes. Okay? If they're up a little bit, I'm okay, because that's part of the disease process. Okay? So big question, should she play? How many people would let her return? 2 weeks, she's a goalie. How many people would keep her out? I would. Okay? Remember, it takes 3 to 4 weeks. She's a goalie. She dives for the ball. Okay? She's the one at risk. Okay? I mean, soccer's a contact sport. So really, we have to. This young lady is not going to be cleared to participate, in my opinion. Will she find somebody that might clear her? Perhaps. But I always do what I think is in the best interest of the athlete. So, okay. Yeah, any questions?